Just want to thank the organizers and Jim, Con in particular, for having me, and thank you, Joe, for that really great overview of some of the core features of universal coverage systems in OECD countries. And so I'm going to pivot a little bit in my talk to the United States, because we have a very distinct milieu here, both political and in terms of the healthcare system. And I want to talk about single payer essential features and really optimal features. So this is going to be somewhat more opinionated. Okay, so let's talk a little bit about the first issue that many speakers have emphasized, that universal coverage is absolutely necessary. So as we know, we are unique among high-income nations in not having universal coverage. We did have two major coverage expansions in the 1960s. Medicare and Medicaid were implemented, and the uninsurance rate fell, and it crept back up in the Reagan era, and it fell once again with the implementation of the Affordable Care Act in 2014. But that still means that we have 9% of the country uninsured, which is about 30 million people, a giant problem. So we need to cover everyone, and we need to do it through a universal public single payer system. Now, that raises the question, what do we mean by everyone? And if we're going to, I think what we mean by everyone is in fact every person living in the country, which does in fact mean we're going to be covering immigrants and immigrants regardless of documentation status. And I'm going to turn back to that. I'm going to turn back to that in just a few minutes to discuss that issue from a policy and a political framework. But first, I want to mention a few other things. So what do we mean by universal public single payer? Well, public, we mean tax financed. And by single payer, we mean that the vast majority of spending is coming from one payer, the government. And what that means in practice is that we are sharply limiting, constraining the role for private insurance. Now, there's going to be more discussion about this later, so I'm not going to dwell on it too much. But I want to focus on one kind of private insurance that I believe needs to be excluded to make our single-payer system work well. Now, there will be, in any system, no matter how generous, there will be certain things that are not covered by the public package. Let's say, cosmetic surgery, for instance. So there will always be some role for complementary insurance for those sorts of things. But the thing I want to address is, what role would there be for duplicative coverage, plans that duplicate the benefits in the public package? And this may exist in some European countries and not be a giant problem, but I think it would be a big problem in the United States, given the size, the power, and the political might of the commercial insurance industry. Now, what are the downsides, though, from a policy perspective? Well, the biggest downside, or one of the biggest downsides, is economic. We know that the overhead of private insurers is extremely high relative to public insurers. In the United States, private insurance companies take 12 cents of every dollar they receive in premiums for their overhead. And what do I mean by overhead? I mean their administration, marketing, executive salaries, profits, and so on. That's an enormous amount of money, and it contrasts with 2% for traditional Medicare and a very similar percentage for the Canadian National Health Insurance System. So we're talking about big bucks that we can't afford to spend. But I want to make a second point, which is that allowing duplicative private coverage into the system is also about equity. So we do live in a world of finite resources, and that is even true in the United States in healthcare, despite the fact that we spend $3.5 trillion on it. And those resources are not just financial, they are professional, meaning physicians, meaning other healthcare providers, meaning hospitals. And there's also the question of political support, and you need all three of them to sustain a public healthcare system of the highest quality. To universalize the best, in Bevan's phrase. And the problem is that when you have a large parallel private healthcare sector, that can siphon off those financial, professional, and political resources. And again, that may not be a giant problem in some countries, but given the size and the power of the commercial insurers in the United States, it could be a real problem here. And we see that there are harms that play out. This is harmful in many countries. South Africa, I think, is an example of a country where the inequality is so large, as Joe mentioned, in terms of the proportion of people who have private insurance and the proportion of healthcare spending that's coming from those private insurers. But even in Australia, a country with a large duplicative private coverage scheme that's subsidized, actually, you see a two-tier system emerging where the median wait times for elective procedures is about 42 days for people with the public plan, but for those with private insurance, the wait times are half that. And that's even true for things like coronary artery bypass surgery, hip replacements, where the median wait time for people in the public plan is about 400 days. So this creates real inequality, and it's because you are siphoning those resources from public to private. And so for that reason, I do think that we should follow our Canadian neighbors to the north. In Canada, the vast majority of the provinces have basically outlawed duplicative private coverage. At least all of the provinces with large urban centers have. And as a result, they've been able to sustain their public healthcare system in a way that I think we have to here as well. Okay, I did promise to return briefly to the issue of covering everyone, including immigrants, regardless of documentation status. Now that is obviously a big political lift. Let's be honest. But it's actually not a policy problem. This was a recent study that actually was led by a colleague of mine at Cambridge Health Alliance. And basically what these researchers did is look at the amount that people pay into private insurance in terms of premiums and the amount they take out in terms of healthcare benefits. And they looked and by nativity status and found that people who were born in the United States actually paid in a little bit less than they took out. Whereas immigrants and undocumented immigrants actually paid in more than they took out. Now, this is not surprising because immigrants on average are younger and healthier, but it does show that in fact they are subsidizing the system to some extent and consequently there's no policy problem in including everyone. There's no policy obstacle. It's purely political. That being said, there is precedent to do this, and the country I would look to in this regard is Spain. Spain is universal system is relatively young. 1986, the law was passed that created it, and in 2011, a public health law was passed that explicitly covered undocumented immigrants. Now, Spain also shows that there are hurdles because the following year, in the context of austerity and the Great Recession, a newly elected conservative government rescinded that coverage. But there was resistance from some regions and in fact from healthcare workers who refused to comply. And in 2018, the newly elected socialist government restored access to immigrants. And there's no doubt still barriers, but it is a case study of a country that shows us that this can be done politically. So let me now pivot to the second question about how single payer would work optimally in the U.S. situation. And I think that's the question of benefits. And so benefits, we've heard this a few times, do have to be comprehensive, right? So that does mean physician care, hospital care, pharmaceuticals, long-term care, vision care, and so forth. But I want to, mention what happens when a country achieves universal coverage but leaves out one aspect of one important benefit. So cost-related non-adherence to medications is a fancy way of just saying people not taking drugs they need because they can't afford it. And if you look at cost-related non-adherence among high-income nations, not surprisingly and unfortunately, the U.S. is number one. About a quarter of lower-income, older adults go without needed medications every year because of cost. But look who's right behind us, Canada. Canada has the second highest rates of cost-related non-adherence. And in fact, Canada has the second highest drug spending among OECD countries after the United States. And that's because when the Canadian system was created, they excluded, they did not include prescription drug benefits. So that's a problem. We don't want to make the same mistake. They are fighting for that now, but we want to get it right the first time. I want to also mention long-term care is very important. Now, it is true long-term care is very expensive, but it can be done. Japan and Germany passed long-term care benefits in the 1990s, and as a result, they have higher proportions of their elderly population receiving long-term care benefits, 10% in Germany, 14% in Japan, relative to 5% in the United States. And despite that, they spend either a little bit less or a little bit more on long-term care in the public sector. It would be more money, but I'm not saying it wouldn't require more expenditures in the United States context, but it does show that it can be done. We can make benefits comprehensive. I want to make a few comments about financial barriers. So this is a slide I sometimes like to show. It's from a satirical publication, The Onion, and the headline is, "Company's HR Manager Really Pushing Infinite Deductible Healthcare Plan." And so I'll explain the joke, which is how you know it's a funny joke, because someone has to explain it to you. The idea is that there's a new plan that the boss is pushing on its workers. It's really great. You can use it at any doctor. You can take it to any hospital. It covers every single prescription drug. The only downside is you have to pay 100% of the costs out of pocket. It's a joke, but there is a kernel of truth. High deductible healthcare plans, as you heard from Jim at the beginning of the morning, are on the rise. And what does that mean? A recent study from last year found that women with high deductible healthcare plans, women with breast cancer, delayed diagnostic imaging, breast biopsies, have delayed diagnoses, and actually have a delay in the initiation of breast cancer chemotherapy. That's awful, obviously. But I want to make further the case that it's not just about high deductibles. Even modest copays can deter care among those who are not wealthy. This is another study that looked at a mere $5 to $15 increase in office visit copays for seniors. And it found that it significantly reduced use of outpatient visits for seniors, which is the point of copays, quite frankly. And it also found that there was a rise in hospitalizations, suggesting downstream harm, suggesting adverse medical complications. This is also true for medications. This is a randomized clinical trial that took patients after they had a heart attack and randomized them to no copays or copays for their heart medications. And what did it find? It found that there was increased vascular events, things like recurrent heart attacks, among those who had copays. Why? Because they weren't taking their medications. And it particularly affected African Americans. So I would argue that we go the way of Wales and Scotland and eliminate prescription medication copays entirely. And in fact, we don't need financial barriers to care for other forms of care, as we know from Canada, where there is no copays for doctor's visits or hospital care. I'm going to take just 1 minute on payment, because we're going to have a lot more on this later in the day. I'll just say briefly that within the single payer context, we need much simpler forms of paying providers. Now, for some doctors in offices, in clinics, fee-for-service might work fine, but for hospitals like where I work, for institutional providers, nursing homes, it makes sense to pay these providers in lump sum global budgets to cover all their operating expenditures, so they don't have to bill for each and every patient. Some hospitals now, there was a recent news study about a hospital in my city where the hospital administrator noted that they have as many billers as they have beds. And that is an enormous waste of money. And so we know from research that this translates into giant spending. The United States U.S. hospitals spend a quarter of all of their revenue simply on administration and billing, twice the proportion of Canada and Scotland. So if we want to get those savings, we need to move to global budgets. Finally, in closing, and again, we're going to hear more about this, another way we should think about provider payments is that the money that hospitals get to take care of patients shouldn't be money that they can then keep as profits and invest. Because A, that's wasteful. B, we need a system of public accountability for investment in new healthcare infrastructure. Because when healthcare infrastructure is being funded out of profits, what you have is places that there already is a very high level of infrastructure, like Mass General Hospital is able to spend $1 billion on a new expansion project. Meanwhile, in downtown Philadelphia, a hospital is closing because its profits are low. So when you have a system in which our healthcare infrastructure is built or maintained or expanded or upgraded where profits are highest, that means further inequality. And that's exactly what we're trying to work against by moving towards universal healthcare. So thank you very much. Thank you very much.
Thank you to our speakers. What we'd like to do is entertain questions from the audience. I think people will be walking around with the mics. I just remind people, raise your hand, identify yourself, and questions end in a question mark. So please, over here.
Hi, thanks for those talks. My name is Tyler. I'm an anesthesiologist at UCSF, and I should add, born and trained in Toronto. I wanted to ask Dr. Gaffney about his slide about the private market in Australia. And isn't it true that there are other countries that have duplicative private services, including the NHS, that has somehow managed to have a very low uptake of those private services? And is there not a reason to potentially include that as an option, especially in a context like the US, where that may mollify some of those people who truly wish to have that option of choice?
Great. So I think this might be an issue we can both speak to. So, the question is, well, I pointed out Australia, but aren't there other countries where there is a duplicative insurance and it doesn't seem to be that detrimental? And I will grant you that I think the effects are different in different countries. And that's, I think, very much dependent on how big that private sector is and on the history of those healthcare systems. I mean, for instance, in the UK, the National Health Service was implemented and created before there was any health insurance, effectively, or private health insurance. And so I think that played a role in reducing its impact. In the United States, I'm very worried about the role that commercial health insurance would have. I think we'd be more likely to go the way of Australia or even South Africa, given the enormous power and influence and lobbying might of the commercial insurance. So that would be my take.
No, I agree. I think a lot of it is how you get there. And as Adam said, I mean, for the UK and in general, in a lot of the richer countries where this market is quite small in terms of expenditures, it's because the core benefit, the universal benefits, and the system delivers care that most people think is good. And this overlap is more for things like direct access to specialists and things like that. And some people pull themselves out of the system. Importantly, they can't pull their contributions out of the system. So this is not an opting out issue, because that would be very dangerous for the system. But I think here, I mean, I don't know enough about our country anymore, but just to say that, I mean, given the history and as I've heard about things like boutique medicine and other things like this, there is a high risk, especially in places where there are relative shortages of physicians and so on, that you're going to be diverting resources to only serve some of the population that has the extra coverage.
Thank you. Right here. Oh, the gentleman in back, and then the gentleman in front, please.
Hello.
Sorry.
Yeah, my name's Robert Lehman. I'm involved in the California single-payer efforts and from labor background. I was just wondering, these are probably more for Joe, 3 areas that I wonder if you could say a little more about. One is, are there particular countries that have been more successful at generating revenue for their healthcare programs from taxing capital sources as opposed to wage sources? The second one is income taxes are notoriously unstable. Are there particular countries that have figured out ways to finesse this problem? And then the third question is concerning countries that have been more successful with doing R&D in pharmaceuticals and distribution of pharmaceuticals and targeting more towards needs rather than what drugs are the most profitable?
Yeah, well, quickly, I don't know about the third question, but let me to address the first two. Taxing capital rather than labor. The way I'm thinking this is really about countries that have broadened the tax base away from labor. I mean, I gave the French example. Another country that has done this over the past, I guess, 15 or 20 years, and it was a progressive thing that was highlighted at the time of the economic crisis. That was actually Hungary, which back in around 1995 or 6, and they have a single payer system, national health insurance system that was funded about 90% from wage-based taxation and 10% from other revenues. It's now 60-40 in the other direction. But the key driver of that was at the time of the economic crisis in Europe when, again, the big social concern was really around employment and wages. And they said, we can maintain our system, our coverage, and so on, but we have to shift the funding base a bit. So they took that as a step. I don't know about the specifics of what the tax sources were, but it was a movement away from labor. And then on the stability issue, I think one thing that is sometimes can be challenging is we try to actually separate the way that money comes into the government budget and the way it goes out of the government budget. What's critically important for any health system is that you have a stable and predictable flow of resources into it. What we've seen is that earmarked sources sometimes work for that and sometimes don't, and non-earmarked sources can also work. It's really about the budgeting process. One of the interesting cases is a very small country, which is Lithuania, which has a formula-based system so that during economic downturns and when employment starts to decline, it triggers a larger increase in the general revenue transfers and when things work the other way. So it's a lagged formula or something, but it builds in this idea that what's not in question is we're going to fund the health system to a certain amount, and then they adjust the sources for reasons that are really non-health reasons. The reasons for the revenue sources shouldn't really have anything to do with health. It's more of an economic consideration, an employment consideration.
Next, yeah, right here.
Oh, this is a question for Joe. I was very impressed by your emphasis on the social consensus in other countries. I'm Mark Saper, retired primary care from here in Berkeley. I was really impressed by your emphasis on the social consensus in other countries, and I wondered, with this whole right-wing populism and neo-fascism that's sweeping the country, is this having an impact on the healthcare systems? Is there pressure? Is there public pressure going generally against that social consensus, or is there a fight of resistance to that right-wing efforts? Because it's interesting, because we've had this effort in England to try and overturn the National Health Service over a number of years before Brexit and all that kind of stuff. But the public is very resistant and fighting back. And we don't know yet what's going to happen with Boris and so forth. But I wonder what's happening in other countries, and do you see any changes there?
Not yet in the health system, but it's definitely a threat. I think what we have seen, and Adam gave the example from Spain about migrants, certainly in Hungary, I just mentioned in a positive way, but obviously they're having, they're quite negative. If you're concerned with covering all people because they're people, then they're really blocking that, right? And there is a concern in some countries of much more kind of nativist ideas and who's entitled and so on. So it is not a big issue yet, but it's definitely a risk in Europe. It's not wonderful over there by any means.
We're going to have to take one last question. Let me ask over here. Please, would you like to?
Hi, I'm Nadia Urato. I'm a physician from Massachusetts. For both of our speakers, could you speak to Taiwan, where they don't have copays, but they seem to be needing to increase the payroll tax to cover the rising cost of healthcare, and the physicians complain about being overworked there as well, and the number of office visits per patient compared to other places that don't have the copay of 6 per year is like 12 per year.
I can say a couple words about the case of Taiwan. So Taiwan, as you pointed out, does have a single-payer system implemented in the late 1980s. I will say the one thing, they do have copays for doctor visits. They are relatively low, but they do have copays. And the reality is that the system has expanded access enormously. It's constrained the rise of healthcare spending. And although as you mentioned, there was a recent article about this in Vox, there is a need to increase payroll taxes. I mean, Taiwanese healthcare spending is extremely low by any standard of high-income nations. I think it's 6% of GDP. And that's, obviously very low. So it very well might be that they need to spend more money on healthcare. They also have much fewer physicians per capita. And so although the doctor visit rates are high, the lengths are very short. So I think that overall, that story, which you may be referring to, implied that the country needed higher copays to constrain healthcare spending or to prevent the system from being overtaxed. I didn't agree with that assertion in the article. We do know in Canada, UK, there's no doctor visits for physician visits, and they do quite fine in terms of overall spending rates.
The only thing I'll say more general, which I think will apply here as well, it really applies everywhere, I think. It's not that there's some sort of magic solution that, you will eventually fix all the problems in the health system and then everything is fine. You fix something 1 year, but you need to continually generate data and analyze and so on. So the system in Taiwan, as we heard, it's done very well on certain things, and then concerns arise. And the issue is to address those concerns. And I think this is something that will be really important, that in some ways, while politically the transition can be made quickly, technically the transition never stops. And so there'll always be this need to come up with, whether it's new technology, whether it's changing health needs, whether there's things completely outside the health system that are affecting access or quality or financial protection. So it's an ongoing process. I know there's a lot of students here, right? So the job security is pretty good in this field.
Always love to hear that, yes. Thank you to our panelists. Obviously a lot here to think about.